Professor Mert. The talk will be about the recruitment maneuver also in healthy lung.
Good. Before I start to talk, sometimes we all sigh, even with spontaneous breathing. Okay? Why do we sigh? This is the first question. Then the second question is, so if I sigh even during the spontaneous breathing, why do I? Okay, I got it. So if I sigh even during spontaneous breathing, then comes the second question: why do I recruit during mechanical ventilation? Because we already mentioned the mechanical ventilation is an unphysiologic process. This is again a historical anesthesia machine from my starting periods. Unfortunately, it is not my own photo, and I have found it in internet. And this machine right here, there's a knob. Over the knob, you can see sigh. And I have asked to my teachers, what is this knob good for? They said, okay, this is a sigh knob, but this is now historical. We don't use it anymore. Forget about it. Sigh is now very dangerous during mechanical ventilation. It was 1990. It's okay. How about the mechanical ventilation? Let's make a little history. The start of the mechanical ventilation was this famous polio epidemic in Scandinavia. It was not that historical. It was in the middle of the 20th century, and that's in Scandinavia. These are the famous pictures from that term, and they were the iron lungs. The iron lung is actually more physiologic than the mechanical ventilation that we use in these days, because the iron lung is a part of negative pressure inspiration. It is like the spontaneous breathing. We create within the thorax a negative pressure to create an inspirium. Otherwise, what we do now is a positive pressure outside the thorax, and this is the unphysiologic one. But unfortunately, the iron lungs were not capable enough to heal the respiratory insufficiency in these patients, and therefore the polio was associated with a very high rate of mortality. What happens then? The famous Ibsen has come and intended the mechanical ventilation, positive pressure mechanical ventilation, and now we have this mechanical ventilation that we have today. But this ventilation is, as I said, an unphysiologic mechanical process because of three reasons. First of all, we have here the positive pressure, which is not the case during spontaneous breathing. Then we have a different gas mixture than we have during the spontaneous breathing with a higher FiO2, and we use some drugs. What happens with this mechanical ventilation? First of all, there's a decrease in the FRC, in the functional residual capacity, that leads to compression atelectasis that I have shown in my first lecture. Then we have a change in the gas mixture, and with the high FiO2, we have an absorption with atelectasis because of the decrease in the rate of in the percentage of the nitrogen, and therefore we have two types of atelectasis. Moreover, we have also an inhibition of hypoxic pulmonary vasoconstriction and also a loss of surfactant. These all lead to atelectasis during mechanical ventilation, even in the healthy lung. So atelectasis can come from decrease in the FRC, the dysfunction of the diaphragm, and the high of FiO2. And atelectasis can lead both to damage in the lung and also to the damage of the lung functions. That means atelectasis can lead to hypoxemia and also to lung injury. What worse is that we, as the anesthetists and the intensivists, can also add to the harms, to the damage of the mechanical ventilation and atelectasis, in terms that we use something that we hope that this can be a therapy, a treatment of atelectasis, which is actually a new hazard. This was the case thank you for this presentation of the study of Bendixen. Bendixen has recommended, unfortunately, the conclusion of this study was large tidal volumes. And remember, I have shown you the effects of large tidal volumes. With large tidal volumes, you can, yes, improve the gas exchange, but you cannot prevent the atelectasis. You cannot treat the atelectasis. And if we use large tidal volumes, you cannot prevent the cyclic opening and closing the alveoli, which is actually the most important reason of the lung injury during mechanical ventilation. Therefore, atelectasis can be even worse with the wrong ways of the treatment of the atelectasis. As a matter of fact, it has been shown that spontaneous breathing improves the shunt fraction and oxygenation in comparison with controlled ventilation. So if it could be possible that we use spontaneous ventilation also during the operations, maybe this would be the optimal ventilation strategy also during the operation, during surgery. Unfortunately, it is not very possible. Therefore, we have to find some way which imitates actually the spontaneous ventilation. That means if I sigh during spontaneous ventilation, I have to let the patient also sigh during mechanical ventilation too. How it comes, I think I can skip this. You see the relationship between the FRC and the closing capacity. Normally, the FRC is very above the closing capacity, and therefore the risk of the atelectasis is very low. But in an obese patient or in a supine laying patient, the FRC comes closer to the closing capacity. And if I get older or if I have a COPD, especially bronchitis, the closing capacity comes closer to the FRC. And if I have a combination of an obese patient and an old patient, it can be really the case, even without the general anesthesia, you can have the closing capacity above the FRC. And if we add the effects of muscle relaxation to this, you can have the closing capacity obviously above the FRC. Therefore, you need to do something to bring the FRC again above the closing capacity. We already have shown in my first lecture that PEEP can be a good solution for this one. But only PEEP does not help to open the already collapsed alveoli. This is the point that I have shown here the video that we have here in the dependent regions of the lung, some collapse of the alveoli. If I apply only some PEEP to this alveoli, this would be the result, unfortunately. You cannot open only with the PEEP the already collapsed alveoli. And the PEEP that you apply goes directly to the alveoli, which are already open. This is not good for the closed alveoli. This is also not good for the open alveoli because they are already over-distended. Now I have to find something to prevent the already opened alveoli to get over-distended, and at the same time this way should help me to open the collapsed alveoli. Let's go back to the analogy that we have done. During spontaneous breathing, it's like a face-to-face talk, and I will talk like this. But during mechanical ventilation, I am the ventilator and you are the alveoli. Therefore, I have to increase my tone a little. It is not that I have to scream, but I have to put some pressure to my tone, and this is PEEP. But it doesn't help for every alveoli here. Because, okay, don't take it personally, the people in the front seats, they are already awake and they are listening to me. But it can be the case that the people in the rear seats can get somehow, okay, a little sleepy, etc. Now I have to find something to wake the people in the rear seats awake, but I don't have to affect the people on the front seat. They are already awake. So increasing my tone further will disturb people who are listening to me now. Now I have to find something for the rear seats, and I have to just scream, hey! This hey is a recruitment maneuver, and this wakes the people who are a little sleepy to wake up. And this would not harm the people in the front side suit. This is the recruitment maneuver, and therefore, this is probably the way to wake the sleepy people, the collapse alveoli here, awake, to open this alveoli. And this is the recruitment maneuver, and this, therefore, this makes sense. So, in that way, I can prevent that in every respiratory cyclus, the alveoli get opened and closed again. This is the most important reason. This cyclic opening and closing is the most important reason of the lung injury. Because you will have otherwise a collapse in every expiration, and therefore you have to prevent this. PEEP do not recruit alveoli, and it only prevents the recollapse of the alveoli. Again, that makes the reason, as we have mentioned before, we have here a pendula. In 80s, in 70s maybe, there was a psi. Then in 90s, it was the case that we had to forget about the psi. And now the psi, the recruitment maneuver, is somehow back. Okay, that is something that we have mentioned before. We have a bundle of PEEP, recruitment maneuver, and low tidal volumes. So I have to increase my tone during my talk, and now and then, if I see some people who get sleepy, I have to scream, hey, to wake them up. But recruitment maneuver can also have some complications. If I scream very often, hey, this would harm people in the front seats too, especially if you would have some ear problems, some ear hearing problems. These screams can disturb you and disturb your hearing. So I have to be very careful. The analogy is for let's say, for air bulla. And if you have bulla in your lungs, the recruitment maneuver can cause a pneumothorax or complications. This is another study showing that the bundle of the protective ventilation would help me to prevent and also prevent the atelectasis and maintain the open lung. If I use only PEEP doesn't help. If I use only recruitment maneuver without PEEP, it doesn't help me either. Only if I use the combination of recruitment maneuver and PEEP, the atelectasis has gone away. So this is the most important part of the study, and therefore it is a very important study of Anesthesia group. But recruitment maneuver can be harmful too. How can I make a recruitment maneuver? There are different ways to make a recruitment maneuver. The easiest way, very simple way, is to make a sustained inflation. You can make it even without a ventilator. Just take it manually, close your valve, take the balloon into your hand, and keep it for, let's say, for 40 seconds in 40 centimeters of water, just like Bendixen has done it some 60 years ago. Even the inventors of recruitment maneuver, even the inventors of the protective lung ventilation say that this is very unphysiologic. This is very easy, and yes, we have to admit, we have to confess, that is the way that we are doing it, but this is not a good way to apply the recruitment maneuver. This can be harmful, especially for the sick alveoli. So what is the other methods? This is one of the most usual methods. It's called the staircase recruitment maneuver. So in that terms, as you can see here, we increase both PEEP and the driving pressure in steps of seconds, or maybe 1 minute, or let's say 4 or 5 ventilator cycles. The driving pressure is constant, as you can see. and we go up to 30 or 35 of PEEP, and your peak pressure or plateau pressure would be approximately some 40 centimeters of water. At the peak here, somewhere here, you would have all your alveoli open. This is the most physiologic way of applying a recruitment maneuver. What is the another way? This was unfortunately the way that we have applied during Provilo study. You can see here we keep the PEEP constant and we play with the driving pressure. This is another way of applying recruitment maneuver. And then before and after this recruitment maneuver, we have to have this ideal PEEP or best PEEP or optimal PEEP, whatever you define it. We had to know it. And to know the best PEEP, first we have to open all the alveoli. That means the PEEP trial should be performed after a recruitment maneuver, because only after a recruitment maneuver you would have all your alveoli open. After this step in recruitment maneuver, you can go down with steps of 2 centimeters of water in your PEEP until you have the best compliance. If I would match here compliance, I would have something like this. Of course, here my compliance would be very low, somewhere low. And then with every step, the compliance would increase, would be better. And let's say somewhere here, I would have the best compliance. That means with the same driving pressure, I would have the best tidal load. That would mean the best compliance. And afterwards, if I drop below the ideal PEEP, the compliance will decrease again. And then I would have such a curve. If I have a decrease in the PEEP, so you can stop your PEEP trial. And that PEEP, let's say here, that PEEP would be your best. Afterwards, you have to perform another recruitment maneuver because you are already below your ideal PEEP. You have to repeat your recruitment maneuver to open your alveoli again. And afterwards, after the second recruitment maneuver, you can apply again the ideal PEEP now, and this would be the best way for protective ventilation. Theoretically, it sounds very good. Practically, during the OR, I know it is almost impossible for all of us to do all these things. And afterward, think about it. You see some secretion there. You want to aspirate the secretion, and you have to repeat all these sequences again. It's quite unpractical. But now we have some solutions. We have better anesthesia machines where we can perform this. This is the study that I have mentioned in my first lecture. They have compared here. They haven't compared, this was a good idea. They haven't compared PEEP versus C or something like that. The control group here, it has also some PEEP. You see 5 of PEEP. But in the study group, they have done this decremental PEEP titration that I have mentioned before. They have found in every patient different ideal PEEPs. In some patients they have 3, in some of them they have 10, or etc. And after the second recruitment maneuver, they apply this optimal recruitment maneuver. This is the good idea in this study. And they have shown, in the study group, they have an improvement in oxygenation, they have an improvement in compliance too. And therefore, it's a good idea to apply this maneuver in every patient. Only in that case, the bundle of the protective ventilation can be helpful. This is the study published in New England Journal of Medicine, but Professor has already mentioned also other studies and meta-analysis showing that the protective ventilation, in that terms, can be very helpful to protect the lung and also the functions of the lung. But the recruitment maneuver is not just paradise. Of course, recruitment maneuver can have also some disadvantages. as I have mentioned before, if your patient has bulea that can explode and cause some pneumothorax, it's a contraindication. You cannot apply your recruitment maneuver in a hemodynamically unstable patient. Do not apply recruitment maneuver in a hypovolemic patient. Every time you apply this recruitment maneuver, you can have a very hypotensive patient, hemodynamic instability, and therefore this can be more harmful than beneficial. Therefore, it is recommended not to use a recruitment maneuver immediately after the induction of anesthesia, because the induction of anesthesia is associated, especially in the critically risky patients, it can be associated with a hemodynamic instability. So how do I have to recruit? We have already mentioned that this method is probably the best method to apply recruitment maneuver. How often do I have to recruit? Every time you open your tube and aspirate, every time you stop the mechanical ventilation, every time there is a leak in your ventilatory cyclus, you have to repeat the recruitment maneuver. And does it work in every lung? Unfortunately not. It can be the case that the lung, first of all, that the lung does not need this recruitment maneuver, meaning that your low inflection point is somewhere at 0, or it can be the case that the lung is very sick, that the recruitment maneuver does not help at all. This study shows that the recruitment maneuver can be beneficial only if you apply it here, like here, almost every 15 minutes. Every time you disconnect the patient from the ventilator. Only if you apply the recruitment in that way, you can have the benefits of the recruitment maneuver. And therefore, it's not easy to apply this maneuver with classical types of the ventilator. How long do I have to do it? This study is interesting from 2008, that in some regions of the lung, some 18 seconds can be necessary to have a whole recruitment of all the alveoli. Newer anesthesia machines are, thanks God, capable enough to apply to recruitment maneuver in the physiological ways too. You only have to give your steps of the peak and steps of the peak inspiratory pressure and the timing of these steps of the staircase. And afterwards, you just have to push the start button, and then you have to give also, you have to set also the peak pressure. I assume that you have already done a peak pressure. You have to give your final peak level after the recruitment maneuver, and with the help of this easy setting, you can probably apply the recruitment maneuver as often as it is necessary. And you can see here in this setting, this is the trend of the compliance. Before the recruitment maneuver and the peak titration, you have here compliance somewhere here. And after the recruitment maneuver, you can see the dynamic compliance is obviously better than the previous. And therefore, at least in this patient, we can show that the recruitment maneuver with the PEEP titration has worked. But back to the Pravalio study, it can be the case that if you not tailorize also the recruitment maneuver, so if you apply it in every patient, also in the patient in whom the maneuver is probably contraindicated, it can be the case that the recruitment maneuver doesn't work. And therefore, we do not know which component of this bundle of protective ventilation is more important. It is the tidal volume, it is the PEEP or it is the recruitment maneuver. And it was very revolutionary, let's say, a study in 2015 in anesthesiology, that the recruitment maneuver can even be, that the protective ventilation is probably not that protective in every patient. And therefore, they, to avoid an over-distension in non-dependent areas of the health lung, the authors recommend to use rather higher FiO2 levels than to use high PEEP and recruitment maneuver. And this has been lead to a discussion between the advocates of protective ventilation with recruitment maneuver and PEEP versus the ones that think that it can be different, there can be a difference between the healthy lungs and the ARDS lungs. And this has been a discussion also in some journals. So the conclusion is recruitment maneuver is a treatment, also with some complication and contraindication, of the unphysiologic consequences of mechanical ventilation, even in healthy lung. It's an inevitable component of the protective lung ventilation, but it can be, as it is a treatment, like every other treatment, it can be also associated with some unwarranted effects on complications and contraindications too. The use in ARDS is obvious, at least for now. It's used in every lung. It's now questioned, but we can say for recent knowledge, if we can use it in a proper way, what I mean, if we can use it in a tailorized, in a personalized way, like the other ways of the other components of the protective ventilation, the benefits of the recruitment maneuver will be more obvious than its possible damages. I thank you again for your patience.
Thank you very much, Professor Mert. Again, very elaborative presentation, and welcome any question. Please.
Lecture, you don't use pre-oxygenation with 100% oxygen anymore in your practice. The reserve of the pediatric patients especially is very low compared to adults, so we use pre-oxygenation to prevent the adverse outcome of failed intubation or difficult intubation. A comparative between the avoiding this adverse event and this short time of pre-oxygenation with 100% oxygen in producing atelectasis.
Unfortunately, it is in my knowledge there are no studies showing or let's say there are no studies comparing effects of different types of different methods of pre-oxygenation in risky patients. In general population, there have been some comparison comparing the classical way of 100% FiO2 versus 0.8 FiO2 plus some CPAP. It has been shown in general population that 0.8% of plus some CPAP was associated with a longer time until the drop of the saturation below 92. The study has a lot of limitations, but still it makes sense. But you are right, we have a lot of some population with higher risk of oxygenation with a decrease of FRC. This is the pregnant, these are some obese patients, some increased abdominal pressure, etc., etc. And therefore, also in pediatric patients, it has to be investigated. But my sense says that if you apply 100% of oxygen, okay, you would have a higher oxygen reserve in your functional residual capacity, but the functional residual capacity itself is decreased because of the effects of because of the nitrogen washout, and therefore I really think that it doesn't make sense anymore, even in different populations, to use 100% of oxygen.
The
Ideal. Always. Ideal body. There is a picture, a MR scan, I think, showing that the vision of the lung of a man who is 80 kilos and of a man who is 180 kilos is the same. So the lung of a 100 kilo man and of a 80 kilo man and 180 kilo man are the same. So the tidal volume should be the same too. Regarding the pediatrics, it's not my subject. Maybe you have to ask it to Professor.
thank you.
I'd like to ask what the feasibility of doing these recruitment maneuvers while doing a thoracic operation or a cardiac operation with one lung ventilation and
Regarding cardiac patient, this will be the next lecture. Therefore, I'm waiting for it. Unfortunately, before you, I can say that I have worked in different centers in different countries in cardiac too. The cardiac surgeons are the worst one because they consider that they know it. This is the worst combination. For example, the urologist doesn't know it and do not claim to that he's knowing it. So therefore, you can play with it. But they think they can see the PEEP and they say, do not apply some PEEP, please. It can harm my anastomosis of the coronary, and this is stupid. And therefore, this is a big question, and this is another topic. But regarding thoracic, I apply recruitment maneuver in almost every patient. But we have seen, that, as I have mentioned before, if we have during one lung ventilation and only the very high PO2, let's say if we apply during one lung ventilation with 0.7 oxygen FiO2, a PO2 of 300 or let's say 250, you would not have an even better oxygenation. And my explanation is that is because the alveoli are already open. There is nothing to open again with the recruitment maneuver. But generally it is not the case, and generally recruitment maneuver works very well during thoracic anesthesia.
Thank you very much for this nice presentation, and are welcome always in Cairo and Egypt. Thank you very much.